My name is Megan. I'm a second-year clinical nephrology fellow, and today I'll be presenting on eGFR and gender. So the objectives for my talk are: why is the sex input included in the eGFR equation? How do gender-affirming hormones affect the muscle mass and creatinine? How do sex differences in eGFR affect patient care? When should we change the sex input in transgender individuals? And how else should we evaluate the eGFR? I have no disclosures, and I did discuss this with the patient, and she consented to have her case shared today. This is the patient that inspired my thoughts about this and looking into it deeper. Jay is a 26-year-old female. She was actually establishing care with me in the general nephrology clinic. She had no specific complaints that day. Her history was that she had had a left nephrectomy when she was 7 months old. She was told it was something to do with decreased blood supply to the kidney, and she was also told that her right kidney is scarred. However, she last saw a nephrologist when she was 10 years old, and her only interaction with healthcare since age 10 was 2 years ago when she started receiving gender-affirming care from Planned Parenthood in a different state, actually. She had no other history. She's not really sure of her family history. She's not super close with her family. Here in Seattle, she lives with friends and works in retail. She vapes nicotine, she has minimal alcohol use, and she has no other drug use. And for her medications, she's on estradiol, progesterone, and spironolactone, and all these doses have been stable for several years now. So she was actually referred to us from the Planned Parenthood in Seattle when they did labs to re-prescribe her spironolactone and found her creatinine was 4.1 and her BUN was 40. Full labs weren't available. So when she met with us, we did labs that you can see here. Her creatinine was still about 4, other electrolytes are stable. Her CBC was okay. PTH was elevated, and her UA did have 2+ protein with UPCR of 1.6 grams. So we did a glomerulonephritis workup, which was negative. An ultrasound confirmed that she had a surgically absent left kidney and her right kidney was 11 centimeters and echogenic, but there was no renal artery stenosis or vascular abnormalities that we could find. We actually looked back, and she had been receiving care at the previous Planned Parenthood prior to Seattle, and they were getting labs there we were able to see. And about a year prior, she had a creatinine of 3.4 to 3.7. So we figured that this was progressive CKD, and we're treating her as such. So then my next question is, what is her eGFR? And just as a reminder, EPIC actually calculates our eGFR with the CKD-EPI creatinine 2021 equation. This replaced the MDRD, which included a variable for race, which was Black or non-Black. But in 2021, the National Kidney Foundation recommended removing race from the eGFR equation because it found that the MDRD overestimated kidney function for a majority of patients who identify as Black, which was resulting in delayed dialysis planning, delayed referrals to transplant, and medication misdosing. This is because race does not delineate distinct biological categories. So a joint task force was created, and they made this recommendation to adopt the CKD-EPI creatinine equation. You can see here it only includes the serum creatinine, the age, and then correction factors for male or female. We also all know the cystatin C equation. If you don't know the actual numbers, here they are. This also includes age, cystatin, and it also includes a gender correction. We generally are using this these days to add information to the creatinine, especially in patients who take medications which impair tubular secretion of creatinine, or when we don't think their creatinine is accurately reflecting their actual kidney function. But the equation that actually is shown to be the most accurate when compared to measured eGFR is the combination CKD-EPI creatinine cystatin C. So I've never seen this written out before. It's quite complicated, but basically it includes the creatinine, the cystatin C, the gender correction for male or female, and the age. So knowing that, we know that EPIC is going to give us the CKD-EPI creatinine 2021 equation. So for Jay's eGFR, with age 26, creatinine of 4, and sex being male, which it was listed in EPIC, the CKD-EPI creatinine 2021 said her eGFR was 20. However, if you change the sex input and use female instead, the eGFR comes down to 15. So this has actually been brought up by the National Kidney Foundation as well. They put out a 2023 guidance document on improving equity in CKD, and they were mostly discussing the recommendations from the task force that had focused on removing race from the eGFR. and how that may affect and benefit patient care. However, in their summary, they did include gender diverse individuals, and I highlighted the important part, which I'll read, which is when managing gender diverse individuals, eGFR should be calculated and reported with both male and female coefficients, and gender diverse individuals can benefit from a more holistic management approach, particularly at important clinical decision points. So in thinking about my patient and how to best care for her, I thought, why is there even differentiations of sex in these equations? So 98% of our total body creatine is within muscle. And even back in 1913, two scientists, Myers and Fine, noted that when they injected rabbits with creatine, the rabbits had increased urinary excretion of creatinine. And through their studies, they proved that creatine was converted to creatinine. The picture here is from a different paper actually validating that a 24-hour urine creatinine measurement is an accurate measure of muscle mass. So you can see the amino acids that create creatine, which is then in the muscle converted to creatinine, which goes into the blood and is excreted in the urine. So through all these studies, we've determined that urinary creatinine excretion is proportional to muscle mass. So again, why do we need a differentiation in sex? Well, it's all on the assumption that people born as men have more muscle mass than people born as women, and therefore men have a higher baseline creatinine production than women. This is also proven to be true. This image shows skeletal muscle mass. The top line is men, the bottom line is women, in a study that used MRI whole body imaging, whereas previous studies had used surrogates such as total body potassium. These patients were not on any hormone therapy. It was just the general population aged 18 to 88 years. I found it interesting that actually there's a greater difference in muscle mass in the upper extremity than the lower extremity between men and women, but overall it holds true. And I think we've all seen this for the majority of our patients. However, it is a bell curve, and we know that patients who are on the extreme ends, either very cachectic or the rare bodybuilder we might see in clinic, we may need to think about other ways to evaluate their kidney function because their muscle mass is going to be influencing this. So why is it that men have higher muscle mass than women? It has to do mostly with testosterone. So testosterone causes direct growth of muscles by hypertrophy of the muscle fibers because there are androgen receptors on skeletal muscle directly. As you can see in the picture, there's also indirect pathways which increase muscle mass from testosterone. It also interestingly inhibits pre-adipocyte differentiation into adipocytes, so it also decreases fat. This is why I assume bodybuilders use testosterone, but it's also been proven in studies looking at HIV-infected men and women. These studies are meta-analyses looking at exogenous testosterone and the changes in body mass and fat-free body mass or lean body mass. And you can see the top chart is men. In the combined meta-analysis, there was a significant difference between placebo and testosterone-treated HIV-infected men, and this is lean body mass specifically. In the bottom, you can see there's a trend towards a difference in women, though it wasn't significant. But in both cases, both men and women, giving testosterone did generally increase their lean body mass. I will say in these studies, the methods of measuring body mass were not consistent across the studies. So we know that testosterone is generally the medication that's given to people who are trans male, but there are a lot of medications also given for trans female. Most people will be on estradiol, although there's many different formulations, oral, sublingual, transdermal, or injectable. And then most will also be on an anti-androgen. Generally, we see spironolactone or another MRA, but I've mostly seen spironolactone. In other countries, they actually use GnRHs a lot. I think we have insurance issues in the US, which is why we don't use it as often here. And then CPA, which is cyproterone acetate, is also used a lot in Europe and not used in the US. Interestingly, progesterones are not recommended when you look at the guidelines, but I have seen patients on progesterones as their anti-androgen. For the sake of this presentation, I'm focusing mostly on patients who are on medications only and have not undergone gender-affirming surgeries. Presumably, similar principles apply as the gender-affirming surgery would change the hormone production. So we know that testosterone does change lean muscle mass, but this is a study actually systematic review and meta-analysis looking at the changes of gender-affirming therapy, so both testosterone and estradiol with or without an anti-androgen, and the changes they saw in the lean muscle mass. So people taking testosterone had an increase in their lean mass by 3.9 kilograms, and people taking estradiol with or without an anti-androgen had a decrease in their lean mass of 2.4 kilograms. The time course for these studies were anywhere from 3 to 12 months, and they did notice a significant change in whether people were taking injectable or oral, and they found a faster rate of rise for injectables. So Jason decided to look into this further. In September of 2022, they put out a systematic review and meta-analysis. They found 4,700 studies initially, and it actually got down to 9 studies in the end that met the inclusion criteria. They were looking at adults over 18 who had received gender-affirming therapy, hormone therapy of any kind, with labs before and after that extended out to 3, 6, and 12 months or longer. Interestingly, none of these studies reported cystatin C or measured GFR, and there was only one study that had a 24-hour urine creatinine clearance. You can see in the top chart the change in serum creatinine over time for transgender men, and there's no significant change at 3 or 6 months, but they found at 12 months there was a significant increase in the creatinine of 0.15. The bottom chart is for transgender women treated with hormone therapy, and there's actually no significant difference at any time point, although there's a trend towards a slight decrease in creatinine at 12 months. This is a visual abstract from the study, so you can see they got down to 9 studies, although it did include a significant number of patients, almost 500 transgender men and 600 women. The only data they're reporting is from the 12 months because that was a significant change for transgender men, but they do note that it does not seem to impact serum creatinine in transgender women. And again, these did not include cystatin C or measured GFR. In the discussion of this paper, they did find a wide range of changes in serum creatinine, and they found that it was most likely due to the type of hormone therapy, the dose, the adherence, and the achieved target hormone levels. There's also a question of whether changes in the creatinine are due directly to muscle mass or actual changes in kidney hemodynamics and the GFR itself. So with that being one of the largest studies that looked at what the information we have, when should sex input be changed? I don't think it really answered that question. And interestingly, this other study came out around the same time, so it was not included in the Jason study. It was out of Mayo Clinic over a good time period, 8 years, and had the same parameters. They wanted labs prior and at 3, 6, and 12 months after initiating gender-affirming hormone therapy. It's much smaller. They only had 84 trans women and 24 trans men, but they found statistically significant changes as early as 3 months. And their recommendation based on their information was that it was most appropriate for people on gender-affirming hormone therapy by 6 months to use their serum creatinine and desired gender to calculate their eGFR. This was also shown in a literature review that was based on recommendations for pharmacists. They were looking at creatinine clearance and ideal body weight because the ideal body weight is part of the creatinine clearance equation. They focused on BMI and lean body mass, and they were looking at the marker of amenorrhea, which was a marker of successful masculinization in trans men. They found that it occurred at 6 months, and so with their study, they concluded also that after 6 months of hormonal gender-affirming therapy, we should be using gender identity to calculate creatinine clearance and ideal body weight. How can this actually affect patient care? Say you have a female, 25 years old, comes into the hospital with sepsis and a creatinine of 2.5. The computer tells you her eGFR is 27, and so you put her on cefepime 1 gram Q12 hours. Same day, a man, 25 years old, comes into the hospital with sepsis, creatinine of 2.5. Epic tells you his eGFR is 36, and you put him on cefepime 2 grams Q12 hours. If either of their reported genders in Epic don't line up with their gender identity and their levels of hormones based on their hormone therapy, you have an increased risk of neurotoxicity by overdosing, and you could have a risk of subtherapeutic dosing as well. And I will say the caveat is we all know AKI is not a steady state, but we still use the eGFR to dose medications, despite us writing in our notes, AKI is not a steady state, and we're all aware of that. What about in a patient who maybe is presenting more with CKD? You have a male 75 in the hospital, creatinine of 1.8, his eGFR is 39, and he's having back spasms. And so you order baclofen, 2.5 grams Q8 hours. Same patient, female 75, creatinine of 1.8, eGFR is 29. Baclofen is actually recommended not to be used at all. In this, if you have too high of a dose, you can risk toxicity with confusion, dizziness, and sedation. If you had changed the dose from something they were on previously and are misdosing them, and they actually have a risk of withdrawal, they could have agitation, muscle rigidity, and seizures. The other place I think this is important is for my patient Jay, again, 26 years old, we're considering transplant. We saw her with a creatinine of 4, which actually puts her eGFR at 20 or below, no matter which gender input you use. But a year ago, I found labs from Planned Parenthood where her creatinine was 3.5. If she had presented at that point with the male input, her eGFR would be 24. She would not yet be listed for transplant. If she was input as female and her eGFR was 18, she would have been listed. Presuming everything else is okay. I'm looking at Dr. Rothford. So how else can we evaluate kidney function? Well, we talked about the cystatin C equation. In that guidance document on improving equity in CKD, they also say that more data is needed on the impact of gender-affirming hormones on cystatin C and the use of these equations in gender-diverse populations. So to remind you, cystatin C does actually include a gender-corrective factor. So is cystatin C affected by muscle mass? Well, it's a low molecular weight protein that's produced constantly by all nucleated cells, and it's freely filtered at the glomerulus and metabolized in the proximal tubule. It can be affected by steroids, inflammation, adiposity, and thyroid dysfunction, but they found that it's more uniformly produced across diverse populations. However, there are some other studies which do find an association between lean body mass and cystatin C levels when they compare them to inulin clearance. Although when I played around with the CKD epi-cystatin C equation, I found that there was not as significant a difference when you change the gender input. So for example, a female 26 with a cystatin C of 3 has an eGFR of 19. The same information with an input of male has an eGFR of 21. So there is less variability overall. So C. Jason again came forward a year later, December 2023, and did a paper looking at cystatin C-based eGFR changes during gender-affirming hormone therapy. This was they looked at much more in-depth studies, actually. It was out of the European Network for the Investigation of Gender Incongruence, which is important just because of the medication choices that they had. But it included 260 transgender women and 285 transgender men. Again, they had baseline labs before hormone therapy initiation and 12-month follow-up. In this, they also evaluated lean body mass changes and the serum levels of hormones, and they excluded anti-androgens except for CPA, which I'll remind you is not actually a medication we use here in the US. They actually defined their target estradiol and testosterone levels for the patients, and they used a cystatin C-based eGFR equation called the FAS, which does not incorporate sex as a variable. What they found is that cystatin C significantly changed for both transgender women, it would decrease, and increase for transgender men. I found this interesting because CPA actually has glucocorticoid properties, which is known to affect the cystatin C. And they also evaluated in this study for changes after correcting for the change in glucose, lipids, blood pressure, body mass index, which are all things that can be affected by hormone therapy. And they found that the change in cystatin C was still significant after controlling for those factors. So this is the visual abstract from that. You'll see we have a connection. Dr. Aurora did this visual abstract for C. Jason. And really interestingly, when they combined the results from transgender men and women, they found that the changes in cystatin C were associated with changes in serum sex hormones. However, when they separated the genders and evaluated them separately, they did not have the same significant association. So they feel that the overall changes in sex hormone concentrations likely had a more significant effect on cystatin C than the specific magnitude of the changes themselves. They also, like previous studies, found that there were more pronounced changes when there were different forms of hormone therapy, mostly injectable. I think one thing that they mentioned in the discussion of this one is that they, again, not sure if the changes in cystatin C are directly from the hormone therapy is affecting muscle mass or other things that affect cystatin C, or if it actually affects kidney hemodynamic function itself. And so they are actually currently doing a study that includes measured GFR and renal plasma flow, which they're studying using iohexol and para-aminohypurate clearance before and after gender affirming therapy. And they have 20 transgender women and 20 transgender men in that study. So with all this information, how does it affect my patient Jay? Well, I had referred her to transplant. She was actually seen this week in transplant clinic. She currently does not have any indications for dialysis. I think if a question of uremic symptoms or volume issues arose, I would be interested in getting a 24-hour urine creatinine clearance and a cystatin C to better evaluate what her actual kidney function might be. And right now she's tolerating spironolactone without hyperkalemia, so I don't feel the need to define her kidney function more. She's not on any other medications that have narrow therapeutic windows, so I don't think any additional testing for her right now will change her management at all. Where do we go from here? So current studies are conflicting, but I think show likely changes in creatinine and therefore calculated eGFR after consistent hormone therapy for 3 to 6 months for transgender individuals. And I think the studies also show that it may affect cystatin C. So I think we as the nephrology providers need to consider the duration and adherence to their hormone therapy and their overall body habitus when we're looking at their eGFR and think about whether the gender input seems correct for them. And I think we should calculate the eGFR with both male and female input. And if it's significantly discrepant and is affecting things like medication dosing, or whether you're considering referring to transplant or talking about dialysis, we should get a cystatin C and a 24-hour urine creatinine clearance to better evaluate. On a larger scale, I think this could affect transplant protocols for listing. I don't know if other transplant centers have a protocol. I know ours does not, and generally is not seeing a lot of patients who are transgender and have discrepant eGFRs. But I think when it came, if she had presented a year ago and her eGFR was above 20 with male and below 20 with female, I think we would have had to talk about appropriate timing of her listing and how to actually calculate her true eGFR. I think it would be helpful if EMRs were updated to show the calculated eGFR with both male and female input if a patient chart indicates that they are transgender. I think right now it's up to the provider to notice that. So usually the sex that's displayed on a patient's chart will be their sex at birth, unless they are in some sort of situation in the medical system where they can update it. If you actually click on that in Epic, it brings you to a demographics and other information page where you can see whether that is actually their gender identity, or if they have a different gender identity, or if that is their gender identity and they maybe had a different sex at birth. Again, this doesn't necessarily indicate whether they've been on hormone therapy, it's just how they identify. And so we also need to know more about their specific hormone regimens. I also think with these studies, we need more studies that are looking at the specific hormones, the duration, and maybe even these target hormone levels that are associated with changes in creatinine and cystatin C, and maybe it needs to be more individualized for each patient as opposed to just male or female input. This is a picture from Lake Ingalls during large season a few weeks ago, and it was the last place I really wished I had more muscle mass myself. But I would like to thank my co-fellows for always bringing interesting patients and being willing to talk about all of our patients. My mentor, Sarah Sangavi, for helping me with the presentation, and for my patient, Jay, for being open to sharing her case with everyone.
Very good. Thank you, Megan. That was a fantastic presentation and very interesting and timely. I think, I think this is something that, we will be encountering more and more as more patients pursue transgender therapies and transgender therapies become more available. So thank you for bringing this to us. We'll open up now for any questions. It looks like to start us off, Kate has her hand raised.
Thanks, Megan. This was a really nice talk and clinically relevant. I've had a few transgender patients that I've kind of sort of, done a bunch of testing, kind of tried to pull it all together for them to, in different ways to explain what all of it meant. And it's been complicated. I also noticed in the VA that they've changed their EHR identification and kind of in the top of the record from male, female to man, woman, and presumably I haven't seen other variants, but now that makes me think I need to look into that a little bit more, understand how shifting to gender versus sex is playing into these different calculations and such. But I wonder, beyond the sort of inaccuracies in using, and I'm thinking about the discussion on race, the inaccuracies that result from using race in the eGFR equation. There's also an additional harm of sort of confounding the concept of race as a biologic versus a social defined factor, which you mentioned as well. And I wonder if these recommendations to kind of adjust our system and use gender, like you're describing, maybe so self-identified gender is making the equation work a little bit better, but still incorporates this confounding or encourages us to confound with a biologic factor. And ultimately, if maybe the equations just they don't work anymore, and we need to use more specific types of tests for kidney function. We just need to change the system if these equations are not working for us. So I don't know.
Yeah, I do think I was thinking about that a lot, because I think with everything we have a bell curve where most people are going to fit into it and then people aren't. And I think the problem with race is that black and white is not biologic. And so there's no bell curve for the general population of Black, because people who identify as Black it's a self-identification. I think for sex, there is a bell curve that most people fit under for this muscle mass and what their creatinine should be. I think gender is fluid. And I think with the hormone levels people achieve, they're usually not targeting a specific level, but rather just symptom relief and what they want themselves to feel and appear. And so I think there probably is a range of hormone levels once we get into the gender spectrum, which is why I think probably the most interesting data would be on hormone levels and how that plays into the equation, because I think that's where we get into the spectrum that's shouldn't be as, not black and white, but shouldn't be as defined with only two inputs.
Right. So in as an analogy, race is a terribly imperfect surrogate. It was our attempted surrogate for some sort of biologic factor that we were trying to identify that we recognize that's just not a good surrogate. Maybe gender, you're saying, is the same. Gender is an insufficient surrogate for hormone levels in this case, or something to that effect. Yeah, thank you. Thank you for that.
Any other questions for Megan? Lots of praise in the chat, and I concur. Excellent talk.